Hi, Milan. Would love to, Milan, start with getting to know you a little bit better.
So if I can even take a step back in my journey, the reason I started my healthcare journey is because my grandfather passed away at a very young age when my dad was 5 years old, and she went back at that time to the nursing school and raised three kids along with uh, giving her whole life to the health. Even when I grew up in the hospital complex, and every day I saw my grandmother work very hard, but at the same time brought smile to her. That kind of led me to start my journey, becoming a doctor in India and then moving up here to the US. And if I had to think of the lessons I learned from my journey and getting inspired from her, I think the three things that really take me home is first one, kind of seeing her every day is service over success. So basically, seva. For most of us, healthcare is a calling. It's not a career, and we always have to prioritize the human element behind every metric. Yes, we always talk about the length of stay and quality metrics and all that, but I think we've got to always see them through the lens of the patient, and I think that is the biggest lesson I learned. The second part was back then, especially when she was practicing, we had very limited resources, especially in the government hospital where she was working, and then I got trained. We don't have unlimited resources, so we have to be very good steward of the resources we have and really work on efficiency. And I think there are definitely places where we can be much more efficient and try to kind of break the iron triangle of healthcare where we are trying to get the access, improved access, decrease cost, and also improved outcome. And the third thing was, and that's something I saw up there, is the family, not just as a visitor who will visit the patient, they are the care partners.
Yes.
So kind of bringing
Right.
families be integral part of the care journey. And that's what I try to do here, even in the ICU when I round. I try to have what we call family rounds, and we involve the patient's family along with the journey and kind of help them understand the disease process, what to expect. And that really helps them. One, they can be taken care of better when they go back home, decreasing readmission, and so on. Summarizing three things: the service over success, resourcefulness, and family as partners. And I think these are the universal principles, whether you're in India or you're in the US. I think that will make healthcare more human and more.
So how have you seen that big mindset shift from fee for service to the value-based care model, and also sort of what's working well there and what's still holding the system back?
And I think to start off with, we definitely are not there in terms of value-based care yet. I think the shift from fee-for-service to value-based care, again, that's a huge shift from doing more to doing right. And I think that's the journey is
Yes.
choppy at best. And I think we always been rewarding people for seeing more volume, seeing more activity. How do we increase our ER volume? How do we increase our hospital admission? And to really kind of go towards value-based care, which is where you're rewarded for the outcomes and prevention. How do you treat the patient? How do you take care of them in that episode, and not kind of take a step back and become a community physician where you are looking at the whole population at large. One is the misaligned incentives. So, for example, hospitals, even currently, more than half the patients are still being paid as fee for service. Every hospital will be in episodic care, but also bundled care, where you now become part insurance for the, let's say, 30 days, 90 days, depending upon if they're in the sepsis bundle or if they're in the knee replacement bundle, or all the way up to the full risk model. So it kind of induces the schizophrenic behavior in the hospital and the doctor. Like, it's very confusing, and still we're learning as along the way, and there are more and more tools that are coming. The second part is the risk adjustment is, for certain patients, you may need a lot more resources. For example, somebody with multiple comorbidities, they have diabetes along with the high blood pressure and so on. They may need a lot more resources. And there is some risk adjustment for those parts, but there is not true risk adjustment from the social determinants of health. Like, so if they don't have transportation, if they don't have money to pay for the medication, and now how do we still, if they're liable for full risk for patients who does not have
Right.
transportation to see the doctor, who doesn't have medication, like money to take the inhalers.
Difficult.
I think that's still, it's a work in progress. The third one is the kind of data infrastructure gap, where you still have the interoperability is nowhere near best. And still we are sharing some data, not sharing other data, and it just creates a lot of barrier because we got to think about like the value-based care. We are thinking as a whole patient and not just what happens in our four walls of the hospital. We want to see the
Correct.
whole journey through, and that's still a challenge.
In general, do you see the provider ecosystem, like the physicians as well as the facilities, the hospitals, sort of excited about sharing this risk, or this is sort of being pushed upon them by the ecosystem?
So I think it can go both ways, depend on what model they are. And especially I've seen the model work better if they're doing like if they're
Hmm.
doctors. And there are certain models like there's a ChenMed and there are other companies out there who
Right.
will employ the primary care doctors and have them only see 300 people, and they have on a fixed salary, not based on the volume. And then on the
Yes.
other side, obviously you have doctors who are just volume based. But the
Hmm.
one in between, those are the harder ones. And it's not as easy to just reset the whole healthcare system and start from the value based journey. Like we want to be profitable and quarter to quarter. When you
Yes.
think about value based journey, you need
10
investment over the
years.
many years before we
Oh,
reap the
yes.
benefits at the end. So again, it's still progress,
You
but
mentioned that you are currently managing full risk for employees, not just for your own hospital, but across about 50 hospitals where the entire end-to-end risk is taken by you. So, how do you, in that population where there is actually no risk sharing with anybody, approach, right? How do you balance cost versus quality?
every market is different and they are on multiple states. So it's not just concentrated in few states. So again, very
Okay.
different way of dealing at different places. But I think overall, I think we've done a good job. We do take on the full risk. It's a self-insured plan. The biggest thing we do want to focus on the quality at the heart. Again, this if you're managing a full risk for a population who is not also your employee, they may have different priorities versus us. The quality is the biggest priority because again, we want our employees to be very productive, not get sick, and all that. So there is also the kind of opportunity cost or hidden cost tied into not providing the good quality of care. So I think the big focus is again the value-based care in this one. So I think there are three different ways we are kind of working through that. The one is really big on the primary care investment, making sure they have
Okay.
the good primary care doctors, good investment in the prevention, and making sure they have the right care. Even the previous places, I think they really focus on. We give example like for gym membership, there is some incentive that may be for that, or doing so many blood check visits or blood pressure visits, and random routine visits that we are kind of encouraging our employees to have. Also, for our hospital, I'm kind of employee doctor as well, so many of the patients are my personal patients too. So really focus to making sure that we do a good job with the primary care, and not just the
Right.
primary care, but also kind of full suite of things like whether it's getting them the right pharmacy, getting them the behavioral health if they need to have nutritional support, and so on. So and again, having availability if they need to be seen, seeing them same day instead of going to the ED. So all those things that we can do to provide the care at the right time, right place. And the second piece, if they do have to seek the care in the hospital, again, we want to
Right.
kind of give the full wraparound service and again, care navigation, structured discharge planning, making sure the medication reconciliation is happening, the kind of high touch support even once they get discharged, getting them into our network facilities to make sure. The third thing is to really, the employees have gone through the care journey, looking back
Right.
and doing the retrospective analysis of where where the costs are, what specialties are they seeking care, if they're going out of network.
Fantastic. Okay.
So we even have data specialty specific, what hospitals they're going to, or what are the reasons they're
Right.
going to, and it kind of helps us understand what can we do better, where can we
Okay.
have strategic investment, whether they're going away because we don't have this cancer specialty. But then in those cases, we will try to, like for example, transplant. Again, that's a very specialized thing. But if you want to then network with somebody who we know provides a good care,
Hmm.
so
Right.
again, the network development and strategic investment that helps us with that part as well. So I think combining all that, I think we tend to do well, but I think that it's a continuous virtuous cycle that we try to look at data, how they're doing currently, but also in
But I think
retrospectively as
owning
well. That's, as I said, like our focus is always the quality, and they know that if we don't
that's the
provide them a
balance,
good
right?
care,
Like between no.
so they know like if we don't provide the good care, they will be out of work longer and it'll be hurting us more in the long run anyway. So as a CMO of the hospital, but also like we try to be the champion of healthcare. We try to do the right thing, and they see how we take care of other patients, and I think that inspires them to let's like. And I want to be in my hospital where I know people. I have my doctors here, and I think that's a goal.
I think
Yeah.
when working in healthcare, that's a big one, right? I know these people, I trust them to do the right thing for me. And while of course, there is the human element in care which is sort of most important, but of late there is a lot of tech, predictive analysis, AI, population level health analytics, etc. that's come in to support the care teams to kind of prioritize, support the right patients at the right time. How are you seeing some of this? Have you adopted some of these tools within either your own self-managed risk population, or even for the population that you're managing where there is partial risk sharing? Let's say you were mentioning about a sepsis patient or a knee replacement patient coming in, then there's a window where you're still accountable for entire cost of care. How are you using some of these tools, AI, population health analytics, to prioritize? What kind of interventions are you then able to drive through that? Would love if you could talk a little bit about that.
Yeah, definitely. So AI is a big buzzword now, and I think
Yeah,
there's a lot of talk about AI, and I think we are just seeing the tip of the iceberg, the amount of things that are going to come our way over the next few years. And I think
true.
biggest challenge right now is there are so many tools available of which we have, whether catering, making the medicine much more personalized, to all the way taking a step back and making an impact on the population health or even the drug discovery and so on. So there are a lot of things that's happening as we kind of think about the clinical flow. Obviously, there are some very good predictive tools out there. There are some not so
Okay.
good, especially with the advent of all this AI and all that. Now anybody can make a new tool next day with this
I mean,
all the chat GPTs of the world.
vibe coding.
So yeah. So obviously we have to really vet it, and I think and we have used lot of different tools, and imaging is again, I think that's been now almost used for a decade in many places that we are using AI to check for early stroke and so on. But I think one
Right.
of the other things that we try to integrate in the day-to-day workflow is some of the things that the now even Epic, which is the biggest EHR
Your EHR,
in the
right.
US, and they have a lot of inbuilt tools. When you're using outside tool, it's still there is a challenge about how do we integrate them. But for
Right.
example, the readmission is always a big concern,
Right.
and it depends on the insurance whether there is a penalty for readmission all the way to no payment at all for the readmission, because of readmission. So I think really want to make sure, and I think, and not just from the cost perspective, there are a lot of studies showing that if they do have to come back and they have worse outcomes, worse increased mortality, and so on. So our goal is to get them appropriate care while they're in the hospital and get them discharged. So one of the tools that Epic has is the inbuilt kind of readmission score, and it basically captures the data which
Predicts
already exists,
probability of readmission. Is it?
probability of readmission. So that comes up with the
Okay.
composite score, which combines the previous admission, previous ER visits, their comorbidities, the length of stay, along with some of the things we already know, like medication adherence, how are they, their social determinants of health, which is also being captured. And we cannot provide probably this care to everybody because again, it'll be cost prohibitive. But again, for the subset of patients
High
who are at
priority.
high risk, then again, while they're in the hospital where we have the captive audience, get them the social work, case management, pharmacist, all the support they need, whatever, understand really their social determinants of health, get the family more involved. If they need a voucher for the transportation, get the meds to beds, which is basically getting the medication for the primary care to get a better transitional care management, get a remote patient monitoring. Again, for example, COPD patient, we can get the remote patient monitoring. They have a home oxygen sensor. So if any times that we see that patient is getting worse again, we can capture them. We can do a televisit. We can, in the past, we have done home hospital at
Home
home
visit.
as well. So there
Okay.
is a full spectrum all the way, the home doctor visit all the way to the full spectrum of care at home. Say it's maybe $1,000, $2,000 cost we take for the one patient for one day admission will prevent $15,000,
$20,000. Yeah.
$20,000. So again, it's the return of investment. It's amazing. I think eventually we'll, with the use of technology and all that, we'll get to the place that we can tool uses for everybody or
Specifically with your experience across these programs like RPM and chronic care management, what have been like the critical factors for success? Like what has helped these programs do well? And when do they become just like,
on the
billing
checkbox.
programs, not really creating impact? So, like, what matters to their success?
I think really the biggest thing, and some of the things that, especially during the pandemic, we were using RPM significantly more, and just started using it as compared to we had nothing almost before. And what
Right.
we missed early on was the patient education. So we
Okay.
we had initially patients who we will send all these things, and they never even put it on. They never check their weight, they never check their blood pressure, and so on. So I
Right.
think that was the biggest barrier, were just patient education, making them really understand this is
Adherence.
helpful for them and not just another thing that gonna come in their mail and they will have to send it back. So I think the
Yeah.
engagement of patient was the key thing, patient education, and then continued high touch services. So again, if they need to understand the value of what they're getting, and I think that was the biggest thing.
I think that's a fantastic point because unless the patient also wants to actually actively stay healthy, right? Whether that's at 40, it's true, and I'm sure at 60, 65, it's probably more true. One other challenge, right, that we've seen when people are running these programs or even just care delivery in general across healthcare in US is staffing. Staffing shortages have been like persistent challenge in hospitals, in nursing homes, in assisted living facilities. How to get maximum care out of the staff that you have. How you've used virtual nursing, has that helped? Like, is that staff basically augmenting your existing staff in the US? What is it that can be done? Because see, even across the globe there are now two types of populations, right? There is aging population in developed countries, and there are countries like India with young qualified workforce. But I think there is a lot in care that today can be done virtually. In fact, we are
Mhm.
doing that in India for India itself, right? So, how do you think that plays a role, and also the balance between, let's say, the global south versus the rest of the developed world, and
Okay.
how that population balance can play a role in the future?
I think you bring up amazing topic. I think that's where we're going to see, along with the AI, I think the biggest revolution we are seeing in the virtual care. And
Okay.
just to kind of start off, before we get into the kind of virtual nursing side, was we had a whole 10-year roadmap as how we were going to do the televisits. And then the pandemic happened when was in a previous place. And we achieved the 10-year roadmap in 1 month. So
Absolutely.
the obviously necessity is mother of invention. So again, I think sometimes when we are in a hard in a rock place, that I think, and this nursing shortage and overall healthcare staffing shortage has been getting worse over the period of years as the aging population, more and more people are spending a lot more time in the later part of their life as they get older. And pandemic really created this supply demand mismatch with all this pandemic going through different regions. They started doing these travel nurses, and it just created a whole disconnect in the market. And I think that's led to a lot of new innovation. Um, and I think we have been using some resources here, but I've seen across like a lot of different ways that virtual nursing can be helpful. And I think if I had to kind of really three big uh, places where it will be used more and more would be, one is the virtual kind of admission discharge nurse.
Okay.
Nurses do think a lot of things bedside day to day. At the time of admission, at the time of discharge, they spend almost an hour behind the computer
Wow.
typing on all the things that they need to do. And which does not really, yes, it's a touch point with the patient, but a lot of things are just more from the administrative
Administrative.
perspective. And if anything, that's growing quite a bit. Other part is like virtual kind of specialty nursing.
Okay.
And again, with this mismatch in where the nurses are and where the care is needed, not everywhere there is a specialty nurses, like somebody who can take care of a heart patient or ICU patient. But
Okay.
if you have on-site regular nurse, you can have this more knowledge expansion through the virtual nursing, where you can get more specialized training to do role in education too, as we kind of expand the role. So instead of having somebody travel there to educate a nurse, which again, not everybody has resources, so you can have it virtually be done to really expand the role, and we can work at their top of the license. And the third thing
which we are also using in our hospital here, and I've seen it many other places. It's something called virtual sitter. So
Oh, yeah.
many
You
times,
mentioned that sometime, yeah.
yeah, and many times though we use any day like at least 10 to 15 people maybe on what we call one-to-one watch. So basically
Okay.
10 to 15 people when we're size of the hospital, it could be much more or less. We'll be just sitting in the patient's room because they may be a fall risk. They may be other behavioral issues. They are just being
But they
there
just
to
need to
watch the
physically
patient.
be looking at the patient.
Yeah. And again, it's a resource that's tied up now. Generally, those are nursing
That's the
aides.
lowest hanging fruit, I think, to be
Somebody's
replaced by
just
a
there.
virtual sitter.
Yeah. And so that one is being managed by the virtual sitter. And now they allows them to look at multiple people at the same time. And it's not just now it can happen from outside of the US as well, because again, that's not a licensed person in a way. It's a nursing
Right,
aide. So
right.
there are already companies in the US where you have virtual sitters from Costa Rica and different countries. But I think there are three benefits, I would say. It benefits all of us. The benefits, obviously, the nurses or clinical staff who's at the bedside now allows them
Right.
to spend less time in documenting, reduce burnout, but more patient care time, more face-to-face time.
Absolutely.
Again, for patient, there are so many studies now showing that it's a faster response time, less fall risk, they're better educator, they're getting more actually high touch points as compared to just not having. And even organization side, it's increased capacity, reduced overtime, cost saving, obviously the better patient outcome. There are some barriers from the culture standpoint. Again, anytime virtual, there's the patients, the doctors, or even nurses that start saying, are you just going to replace us or it's not the same as you have? But again, I want to drive that point home that it's augmenting the services we already have. It's not really replacing anything.
It's in fact sometimes giving them better quality work, right? More patient interaction, improving the kind of engagement that they have with the patient. And are you also seeing, Dr. Milan, any of like such facilities being used in the in between visits, like you said, right, on the care coordination, on chronic care management? Are you also leveraging or seeing this sort of thing being leveraged where there is some staff augmentation happening and on that front?
Yeah, no, definitely. I think the virtual care, the transitional care management visits or chronic disease management, I think definitely we can
Right.
use. Even RPM could be augmented by virtual visits along with it.
Correct.
So I think, yes, there's definitely a lot of opportunity as we kind of more shift towards the value-based care.
Absolutely. One
Yeah,
other fascinating thing that you spoke about when we last spoke was during discharge or even any patient who's with you for a short while, you're not always looking at just treating that episode or that illness, right? It's always about understanding the patient holistically, identifying any other related health issues that they might have, could be behavioral health, addiction, or any other related health issues, and therefore making like a care plan for the patient that is more holistic, not just to manage that one sepsis or one health issue that they came to treat. So, is that something that again is sort of uniquely your hospital, your thing, or again, do you see that happening across the board? Because that's again fantastic, right? Something that, like, even in India, absolutely missing, right? I don't think anybody cares what happens to the patient between one visit and the next. Though there are multiple things about the Indian ecosystem which are also fantastic, right? Like access is easy across the board, not just for physicians, but for any services. In fact, you'll find them at such price points that it'll surprise most Americans to no end. Yeah, like it's basically still a fee for service model in India. And therefore, the only time people bother is that, okay, what have you come to me for? Let me just treat that. So, your perspective on trying to identify like a holistic patient health was very kind of unique. And I wanted to understand, when did you start that? How are you doing it?
yeah, you're absolutely right. And I think India is also, and Circle Health is already doing it to look at the full spectrum of
Yes.
healthcare issues. Similarly, US again, I think, and behavioral health and addiction, it already comes with the stigma associated with that. Nobody wants to talk about it. And I think out of all the comorbidities, I think that gets ignored the most, even for the patients, their families, and the healthcare providers as well. But I think on the flip side, that's probably the biggest reason for majority of readmission, the behavioral things or the addiction issue. And it's very, very important
Social
to
determinants, like you said, right?
yeah, and it's very, very important to kind of understand the underlying cascade of event that led to the acute episode. And really, so for example, whenever the patients come to our hospital, and we try to recognize any of the underlying issues that may be contributing to the admission and try to get them enhanced services. We are fortunate that we have addiction specialists in-house. We have the psychiatrist in-house. We have also a huge outpatient behavioral health services unit, so get them services there. We also do a group sessions that can come back in to kind of help with this, kind of breaking down the stigma and also have them more engaged to get the delivery they need. And that really helps. And I think the unique thing about being in New Jersey, New Jersey has a
Right.
program called NJ Quip, it's Quality Incentive Program. And in that
Okay.
one, it's related to Medicaid population. We try to do it for everybody who comes to the hospital.
Okay.
Is there are certain matrices that we get measured on as it relates to the behavioral, whether we are addressing those issues while in the hospital, even ER visits, and are they seen within the 14 days? Do they have continuous engagement in 30 days? And there are hundreds of thousands of dollars, not millions, are attached to that. So I think that's a
Wow.
nice incentive,
So there is
and in a way,
incentive to do the right thing.
and I think so, as we were talking about proper risk adjustment, that's not present in many of the models with the value-based. I think this will be a nice framework that is a good return for the hospital, good for the patient, good for the community as a whole, as we kind of work towards the value-based care.
No,
But I think
fantastic. But Dr. Milan, see, you're a large hospital, a large health system. There are many things that you can do, access that you have, both in terms of data, the kind of EHRs you use, the ability to staff and have that sort of team. If there is a single physician or a small physician group that wants to start some initial actions towards value-based care, either through running simply RPM programs, CCM programs, how would you advise them to start? Like, what is the best way to start? And what are some of the things to sort of focus on if you want to start on this journey? Because ultimately, I think the whole ecosystem is moving there.
uh, so. Yes, I think that's probably hard to begin with because again, but there are some incentives out there. I think if you're a single physician, if you want to start on a journey on value-based care, you
Right.
can start again. You can join an ACO. It's accountable care organization where you can be part of that and try to take on the partial risk. There is some risk
Okay.
sharing models are available for individual physicians as well, where you can
Okay.
work with the insurance companies. And if you save so many dollars, there are some HMOs out there. You can be part of that and take on the risk that way. And also, you still got to attach to some hospital or some network to make sure you have access to all the medical records and so on. There are certain ways that people are looking at the value-based medicine from the concierge medicine standpoint,
Okay.
which I know some people who they will charge like $1,000 a month or $1,000 a year, depending upon what patient population they're catering, and they will only carry.
Okay.
Which primary care will have 1,500 to 2,000 patients in their panel. They will just try to
Right.
limit to 100, 200, and really
Okay.
deliver a more wraparound service, deliver everything that they need. Their salary is supported by their monthly, and sometimes the insurance will be willing to pay that money as well,
Okay.
and to really manage their care. And if you have a champion like that, like one physician who is available for you at the
Right.
fingertips, then you can really manage the journey, and the provider can really make the phone calls and all that, do all those things to get the best
Yeah, I
care
think that's
possible.
a rare privilege in the
Privilege.
US to have that you have like one physician who's just available for you. And of course, somebody's got to pay for that privilege, I guess.
Yeah,
Is there a startup idea in healthcare that you are really excited about?
I think there are a lot of ideas being thrown around in the world of AI. I think there is but it's not an easy one, especially if you're looking at from the population health standpoint. Again, I think in the world of chronic care management, I think the concierge, there'll be one. There are multiple ways
Interesting
you
one.
can do a concierge. Concierge you can do. Even looking from the RPM standpoint, that I think there is a again, it's a tried and tested, but still, I would say very, very underutilized. And
That's
not everybody
no.
does it right.
Okay.
And that's part of the reason. I think there is already a funding available from the Medicare side for the RPM. So it can be
Right.
sustained, and you just have to have the right connection, right resources to make sure that it's not as innovative as you would think from startup world, but I think it still can make it very
No, no,
successful.
absolutely. I think anybody who's a startup is not trying to solve the large problems, right? Like anyone I know is trying to solve a small problem, but make it a little better, make the patient's life a little bit better, physician's life a little bit better.
Yeah.
Yeah.
Especially now with the AI, there's a lot of still we spend time in the billing and coding, which can be easily automated.